Dear guests, welcome to the Gilead meeting. COVID pandemic has negatively affected the whole world for the last 1 year. Liver disease appears as an important risk factor for patients with COVID-19. My friend, Professor Yusuf Yilmaz from Marmara Medical Faculty will give a speech titled Monitoring Chronic Hepatitis B Patients During the Pandemic to Prevent Drug Toxicities at this meeting. Participants may ask their questions via chat. Discussion will be held at the end of the session. Now, I would like to invite Professor Yilmaz to give his speech.
Good afternoon, ladies and gentlemen. I'd like, first of all, to thank the organizers of this meeting for inviting me here today. It's an honor to have the opportunity to address such a distinguished audience. For those of you who don't know me already, my name is Yusuf Yilmaz, and I am the director of the Institute of Gastroenterology at the Marmara University in Istanbul. What I like to present to you today is the monitoring of patients with chronic hepatitis B during the COVID-19 pandemic. I'll address the subject with the ultimate goal of preventing drug toxicities. Today's topic is of particular interest to those of you who are involved in the clinical care of this patients group in these unprecedented times. First of all, I'd like to give you a short overview of the COVID-19 pandemic. As well as severe acute respiratory syndromes, coronavirus 2 has spread globally, causing a pandemic with more than 170 million infections worldwide and 2.6 million fatalities so far. COVID-19 is usually mild, but around 20% of infected individuals develop severe respiratory symptoms that require hospitalization and, in some cases, intensive care support. Although the pathogenesis of SARS coronavirus 2 infection is not entirely elucidated, some patients develop an excessive immune response to the virus, ultimately leading to the so-called cytokine storm. Let's now consider the impact of the pandemic on the clinical management of HPV-positive individuals. Clinical guidelines recommend that HPV therapy should be initiated and continued regardless of COVID-19 status. However, access to healthcare has been constrained for HPV-positive individuals as a result of myriad of interdependent factors, including redirected finances, redeployment of healthcare workers, closure of facilities, supply chain disruption, movement restrictions, fear of entering health facilities, and impracticality of telemedicine in many settings. This brings me to a dramatic example of what happened to HPV patients during the pandemic. And this example is what took place in Italy at the peak of the first wave. In this country, 1 out of 4 hepatology wards had been converted into COVID-19 wards. Moreover, the services of 1 in 4 outpatient hepatology clinics had been completely stopped at this point. Further, the initiation of drug treatment for HPV was postponed in 23% of centers in Italy. On other note, consultations for chronic hepatitis B in Japan, Singapore, and the USA decreased significantly compared with 2019, with the largest drop being observed for adults older than 65 years. And as for COVID-19, we are aware that the most important clinical manifestations are related to lung injury. However, pathological clinical findings can also occur in other organs such as liver, heart, pancreas, and kidneys. This is likely due to multiple organs expressing the main viral entry receptor, which is ACE2 receptor. Due to receptor distribution throughout the body, SARS coronavirus 2 may infect hepatocytes and bile duct cells and cause the abnormal liver function seen in these patients. The abnormality in liver function tests are particularly abnormal in severe COVID-19 cases, and the rate has previously been reported around 14 to 53%. I also wish to highlight how elevated liver enzymes could indicate an acute liver injury associated with COVID-19. Now I will present you a very important study published in the Journal of Hepatology. Researchers evaluated outcomes following SARS coronavirus 2 infection in patients with chronic liver disease. Two international registries that collected data on chronic liver disease patients with SARS coronavirus 2 were used for the study. Data from 745 chronic liver disease patients from 29 countries, including 386 of whom had cirrhosis and 359 did not, from between March 25 and July 8, 2020 were included. The study found high rates of hepatic decompensation and death following SARS coronavirus 2 infection in patients with cirrhosis. Mortality was 32% in patients with cirrhosis versus 8% in those without. According to Chai-Turk class, mortality increased in stepwise fashion. Advancing age and alcohol-related liver disease were also risk factors for death. Results revealed that the baseline liver disease stage and alcoholic liver disease are independent risk factors for death from COVID-19. And then I wish to highlight that hepatitis B may be reactivated in patients with severe COVID-19 as a result of immunosuppressive therapy. COVID-19 may lead to severe lung inflammation, and for this reason, patients are treated with immunosuppressive therapies aimed at limiting immune-mediated damage. Corticosteroids, dexamethasone, interleukin-6 receptor antagonist tocilizumab, and interleukin-1 receptor antagonist anakinra and JAK inhibitors tofacitinib are some of the drugs that have been used in patients with severe COVID-19. The use of these drugs may pose a risk for patients with active or past hepatitis B virus infection. Let's now look at the relationship between hepatitis B reactivation and immunosuppressive therapy in general. Hepatitis B reactivation associated with immunosuppressive and biological therapies is an important cause of morbidity and mortality in patients with current or past exposure to HPV. In hepatitis B surface antigen positive patients, Hpv reactivation is defined as a sudden and rapid increase in HPV DNA levels in patients with previously detectable DNA or reappearance of HPV DNA. In individuals who did not have viremia before the initiation of immunosuppressive therapy. In individuals who are initially negative for hepatitis B surface antigen and anti-HB core positive. HPV reactivation is defined by appearance of hepatitis B surface antigen and or HPV DNA. Following HPV reactivation, ALT elevation can occur, and in some cases, this can evolve into a fulminant hepatic failure. Let's now address briefly the clinical characteristics of patients with COVID-19 and HPV infection. The risk of HPV reactivation is highly dependent on the status of HPV infection, as well as on the type of immunosuppressive therapy. The highest risk of reactivation occurs in patients with active or past HPV infection treated with B-cell depleting agents such as rituximab, and in hepatitis B surface antigen positive patients who receive high-dose corticosteroids, anthracyclines, or potent TNF-alpha inhibitors. Except for high-dose corticosteroids, all the immunomodulators used to treat cases of severe COVID-19 are considered of low risk, particularly in hepatitis B surface antigen negative anti-hepatitis B core positive patients. I will now present a study to shed more light on the characteristics of liver function in patients with SARS coronavirus 2 and chronic hepatitis B virus co-infection. In the present study, they found that liver test abnormalities were relatively common in patients with SARS coronavirus 2 and chronic HPV co-infection, and the levels of AST, ALT, total bilirubin, alkaline phosphatase, and gamma GT increased substantially during hospitalization. A small proportion of patients developed liver injury. A notable finding from this study is that the proportion of severe COVID-19 was higher in patients with liver injury. The mortality was higher in individuals with liver injury, 28% versus 3%. In the same study, 14 patients, 13% developed liver injury during hospitalization. The interval from onset to hospitalization of patients with liver injury was 9 days, developed liver injury within 1 week of admission. Liver tests of most patients recovered normally after 8 days. However, the other 4 patients rapidly progressed to acute on chronic liver failure, and all of them died of multiple organ failure. You may have heard about ongoing collaborative efforts for investigating clinical outcome of patients with chronic liver disease who developed COVID-19. 2 joint international registry, Secure Cirrhosis and Easel supported COVID-HAP, are currently being implemented. These projects intend to record how pre-existing liver disease or liver transplantation affects the course of COVID-19. Analysis showed that the severity of underlying liver disease has been associated with an increased risk of mortality in patients with COVID-19. As you noticed from this slide, deaths occurred in 7% of patients with chronic liver disease without cirrhosis, whereas 31% in patients with cirrhosis. Before I move on, I'd like to summarize the results of this recent study from Turkey, showing that ALT and AST elevation and AST-ALT ratio more than 1 was associated with more severe course and increased mortality in COVID-19. And here is a summary of how different liver function tests correlated with unfavorable clinical outcomes in COVID-19. Of note, another recent study from China reported that SARS coronavirus 2 and Hpv co-infection increases the risk of host function dysregulation at the onset of COVID-19. SARS coronavirus 2 and Hpv co-infection did not significantly affect the outcome of COVID-19. However, at onset of COVID-19, SARS coronavirus 2 and Hpv co-infected patients showed more severe monocytopenia and thrombocytopenia, as well as more disturbed hepatic function in albumin production and lipid metabolism. Most of this arrangement could be reversed after recovery from COVID-19. Thus, caution needs to be taken with the management of SARS coronavirus 2 and Hpv co-infected patients. Another study examined the temporal course of liver function test in 4 patients with severe COVID-19. The 4 severely or critically ill patients all were male. These 4 patients were admitted to the intensive care unit. 3 required non-invasive mechanical ventilation, and all were treated with corticosteroids. During the intensive care unit treatment, Case A developed deep venous thrombosis, Case B and Case C developed acute respiratory distress syndrome, and Case D developed upper gastrointestinal hemorrhage, liver failure, and renal insufficiency. As a result of the follow-up liver function test of the 4 patients during hospitalization, increase in ALT level was significantly higher than AST, and the ALT increase is the primary indicator of liver injury in COVID-19 patients. The gamma-glutamyl transferase increases was not significant. Before discharge, liver function of 4 patients could not return to baseline. As you can see on the screen, let's now provide a summary of the key concepts we should be familiar with when considering COVID-19 in patients with HPV. Unique consideration in those with HPV infection involve possible precautions for HPV therapies in those with or without SARS-CoV-2 infection and COVID-19 manifestation of abnormalities in hepatic biochemical tests. In those patients with HPV, it is important to be aware of the risk of Hpv reactivation related to medications such as tocilizumab and corticosteroids used in the context of COVID-19. Reactivation of Hpv following the use of tocilizumab and prednisone has been described, and thus prophylaxis agent against Hpv reactivation should be consideration. In addition, chronic HPV therapy, where indicated as per guidelines, can be initiated in those with newly diagnosed HPV and continued if receiving therapy regardless of COVID-19. At this point, let's move on by providing an overview of the current guidelines and recommendations. Let's start off by saying that abnormal liver function or liver derangement, either in the forms of hepatitis, cholestasis, or both, can be observed in patients with COVID-19. The clinical implications of liver derangements might be variable in different clinical scenarios. There is evidence that SARS-CoV-2 might be aggravate liver injury in patients with chronic viral hepatitis. Importantly, drug-induced liver injury during the treatment of SARS-CoV-2 infection should not be ignored. The drugs, particularly corticosteroids, might also cause indirect liver injury through reactivation of underlying liver disease, such as chronic hepatitis B virus infection. And how should we manage patients with liver derangement during the COVID-19 pandemic? Let me elaborate on this point. Systemic high-dose corticosteroid and tocilizumab had been advocated for treatment of patients with COVID-19 who are critically ill. This regimen might cause hepatitis B virus reactivation, hepatitis flare, and acute liver failure in patients with chronic HPV infection. Therefore, screening for hepatitis B surface antigen is recommended, and antiviral prophylaxis with nucleoside analogs is recommended in all patients with severe COVID-19 who test positive for hepatitis B surface antigen during corticosteroid therapy. Furthermore, there are other interesting details we should take a look at. This table lists the drugs that have been used for the treatment of COVID-19 and their associated liver safety. It is important to note that liver derangement might be due to drug-induced liver injury, underlying medical disease, or concomitant medications. In patients who do not have COVID-19, elevation in concentration of serum ALT, AST has been described in individuals receiving interferon, lopinavir, ritonavir, tocilizumab, or remdesivir. Isolated cases of severe liver injury in patients with COVID-19 have also been reported rarely. In addition to this, I'd like to point out the following recommendations. Patients with COVID-19 and persistent liver derangement should have standard investigation for liver disease. The choice of investigations will depend on the clinical presentation and pattern of liver injury, but should involve at least serological tests for viral hepatitis. The optimal interval for liver tests is uncertain. However, it will be reasonable to monitor liver tests twice weekly in patients on potentially hepatotoxic medication, patients with pre-existing liver disease, and more frequently in any patients with abnormal liver function. If systematic corticosteroids or other potent immunosuppressants, for example tocilizumab, are used as COVID-19 therapy for 7 days or longer, screening for hepatitis B surface antigen is recommended. Antiviral therapy for HPV should be initiated to avoid Hpv reactivation and hepatitis flares in patients with known HPV infection. Concomitant use of TDF or TAF with lopinavir-ritonavir is relatively contraindicated as drug concentration of tenofovir might be increased. Tenofovir might be temporarily switched to entecavir during the use of lopinavir-ritonavir in the absence of entecavir resistance. But I want to remind you that lopinavir-ritonavir is no longer recommended in patients with COVID-19. And these slides cover other recommendations. Do not stop oral nucleoside antiviral therapy for HPV at the time of COVID-19 to avoid the risk of Hpv reactivation and clinical flare. Prioritize resources to continue usual surveillance imaging in patients who need hepatocellular carcinoma surveillance the most. An arbitrary delay of 3 months in patients with relatively low risk of hepatocellular carcinoma is reasonable and might be necessary if COVID-19 outbreaks are ongoing in the region. Reduce the number of patients coming to transplantation clinic per session for assessment. Only assess patients with hepatocellular carcinoma or patients with high MET scores who are likely to benefit from immediate liver transplantation listing. Telehealth should be available to most transplantation centers. In patients with non-decompensated cirrhosis, decisions about intensive care unit support should be made on a case-by-case basis, taking into account baseline liver function, previous episodes of liver decompensation, and transplantation eligibility. At this point, I'd like to draw your attention on AASLD COVID-19 recommendations. They specifically state the following: continue treatment for hepatitis B if already on treatment. There is no contraindication to initiating treatment of hepatitis B in patients without COVID-19 as clinically warranted. Initiating treatment of hepatitis B in patients with COVID-19 is not contraindicated and should be considered if there is a clinical suspicion of hepatitis B flare or when initiating immunosuppressive therapy. And then let's consider the BASL COVID-19 recommendations. They state patients with stable chronic hepatitis B or C or metabolic associated fatty liver disease or cholestatic liver disease may have increased susceptibility to SARS coronavirus 2 infection. Among COVID-19 non-infected patients, continue treatment for hepatitis B and hepatitis C if already on treatment. For newly diagnosed patients, proceed with antiviral treatment of hepatitis B and C as clinically warranted. After that, they state that among infected patients, continue treatment for hepatitis B if already on treatment. Initiation treatment of hepatitis B in patients with COVID-19 is not routinely warranted, but should be considered if there is a clinical suspicion of hepatitis B flare or patient is planned for treatment with interleukin-6 monoclonal antibody or other immunosuppressive therapies. And as you can see on the screen, the Easel ECMID position paper has maintained that chronic viral hepatitis does not appear to increase the risk of severe course of COVID-19. Use telemedicine, local laboratory testing for follow-up visits in patients under antiviral therapy, send follow-up prescriptions by mail. Let's now move on to examining the long-term safety of oral antiviral treatment for chronic hepatitis B. First, I wish to highlight that the development of oral antiviral treatment with nucleoside analogs has revolutionized the management of chronic hepatitis B in the last 2 decades. At present, 6 NAs have been approved as antiviral therapy for chronic hepatitis B. These agents are classified according to their chemical structures. The 3 nucleoside analogs include lamivudine, talbuvudine, and entecavir, whereas the 3 nucleotide analogs include adefovir, TDF, and newly approved TAF. Most chronic hepatitis B patients require long-term, if not indefinite, nucleoside analog treatments. This raises a legitimate concern about the long-term safety of NA therapy. Although NAs are generally safe and relatively free of major side effects, nephrotoxicity and bone toxicity may occur in a small yet significant proportion of patients receiving older generation of nucleotide analogs, for example, adefovir and TDF. Muscle toxicity and peripheral neuropathy are unique adverse events reported in patients treated with talbuvudine. Other rarer side effects, including lactic acidosis, which may happen in very sick cirrhotic patients. This brings us to the problem of nephrotoxicity. Chronic HPV infection per se is known to increase the risk of chronic kidney disease, such as membranous glomerulonephritis. On the other hand, all NAs are renally excreted. Older generation of nucleotide analogs, that is adefovir and TDF, are known to be associated with a small but non-negligible risk of nephrotoxicity. Mechanisms of nucleotide analog-associated nephrotoxicity include inhibition of tubular cell transport, accumulation of endogenous compounds leads to toxicity in short term, and mitochondrial injury in long term. With respect to the mechanisms of nephrotoxicity related to NAs, adefovir and tenofovir are subsets of organic anion transporters OAT1 and OAT3. They are excreted by multidrug resistance protein MRP4. Adefovir and tenofovir would be actively transported by MRP4 to the proximal tubule. When MRP4 is saturated, adefovir and tenofovir may accumulate in the intracellular environment, leading to tubular damage. The issue of TDF-related nephrotoxicity is going to be less relevant in the near future, as a new generation of nucleotide analog, TAF, has been approved in most parts of the world. The latest Easel practice guidelines for chronic hepatitis B recommend TAF as the one of the first-line NAs. TAF is preferred over TDF if a patient has or is at risk of renal or bone disease. With the similarly potent viral suppression, TAF was shown to have better renal and bone safety profile compared to TDF. Here are the results of a study suggest that use of TDF and entecavir could be associated with reductions in kidney function in patients with chronic hepatitis B viral infection. The eGFRs of patients treated with TDF were reduced in a time-dependent manner, whereas the eGFRs of patients treated with entecavir increased or decreased across various time points. TAF, as the first drug of choice for treatment of chronic HPV infection, could be used in patients with decreased renal function or in those with risk factors for renal dysfunction, and TAF plus talbuvudine or talbuvudine alone could also be considered for these patients. This brings us to consider a case report of entecavir-induced Fanconi syndrome. The patient was a 73-year-old man admitted to the hospital because of renal dysfunction. He also presented with hyperaminoaciduria, renal diabetes, phosphaturia, hypophosphatemia, hypokalemia, hypuricemia, and hyperchloremic metabolic acidosis, supporting a diagnosis of Fanconi syndrome. In this case, the cause of Fanconi syndrome was most likely entecavir, which had been administered as needed depending on his renal function for 5 years. After drug discontinuation and replacement with TAF therapy once a week, the patient's kidney function recovered and electrolyte anomalies partially improved. The fact here was highlight that entecavir may induce severe renal dysfunction, which can cause the development of Fanconi syndrome. Therefore, close monitoring of proximal tubular function is recommended during entecavir therapy. In another case report, a 44-year-old woman patient with chronic hepatitis B cirrhosis and lower extremities edema was presented. The biochemical parameters of serum and urine revealed the typical manifestation of Fanconi syndrome, and the kidney biopsy showed extensive proximal tubule necrosis, tubulointerstitial nephritis, and mitochondrial swelling. The notable finding in this patient is the TDF-associated nephrotic syndrome, heavy proteinuria, hypoalbuminemia, and generalized edema developed after TDF exposures and resolved after TDF withdrawal. Effacement of food process in kidney biopsy, which has also been found in previous case of TDF nephrotoxicity, supported the idea that TDF caused the heavy proteinuria. Here is the description of 2 cases with TDF-associated nephrotoxicity who are being treated for chronic hepatitis B infection. The first patient, 76-year-old man with Hpv-related liver cirrhosis, admitted for acute renal dysfunction, was found to have clinical manifestations of proximal renal tubular dysfunction and histopathological evidence of acute tubular necrosis at 5 months after starting TDF treatment. The second patient, 50-year-old man with Hpv-related liver cirrhosis, complaining of lower extremity edema, developed acute kidney injury at 17 days after commencing TDF, and he was found to have membranoproliferative glomerulonephritis with acute tubular injury. The renal function improved in both patients after discontinuing TDF. Okay, let me now turn to issue of bone toxicity, which is another major concern, as chronic hepatitis B by itself also affects the skeletal system. It is believed that NAs do not have direct bone effect. Instead, their effect on renal proximal tubular can be associated with phosphaturia and bone loss, reduced BMD, and even hypophosphatemic osteomalacia has been reported in patients receiving adefovir or TDF treatments, though the latter has only been reported in TDF-treated patients co-infected by HIV. In a population-based study in Hong Kong, NA-treated patients had similar risk of incident hip fracture, vertebral fracture, and all fractures compared to untreated chronic hepatitis B patients. Yet nucleotide analogs exposure increased the risk of hip fracture, but not vertebral fracture and all fractures. This is a schematic representation of the association between phosphate metabolism, phosphaturia, and bone loss. The effect of nucleoside analogs on renal proximal tubules may lead to phosphaturia, which subsequently increases the activity of parathormone and hence bone resorption. Fibroblast growth factor 23 regulates urine phosphate excretion capacity. Vitamin D deficiency, which is common in patients with chronic hepatitis B, also contributes to hypophosphatemia. And this study found similar BMD increases with TAF and decreases with TDF for geriatric versus non-geriatric patients. Consistent with advanced age, declines in eGFR were more pronounced in geriatric versus non-geriatric patients, but less prominent for TAF versus TDF treatment in both age subgroups. Before I move on, I'd like to recap the main points related to the comparison of TAF versus TDF. TAF provides approximately 90% lower systemic levels of tenofovir, which would reduce the accumulation of tenofovir in the tubular renal cells. TAF represents a helpful treatment option for both naive and TDF-exposed chronic hepatitis B patients. Let's now turn on the potential occurrence of fetal lactic acidosis, which is a labeled box warning of all NAs, mainly based on the well-established association between lactic acidosis and antiretroviral therapy for HIV. There had been sporadic reports on lactic acidosis occurring during HPV treatment. Based on published cases related to TDF and entecavir, renal impairment seemed to be an important contributing factor, probably due to mitochondrial toxicity if renal dosage adjustment were not promptly enforced. A high degree of clinical awareness of its possibility is required, especially in patients with multiple comorbidities, poor renal reserve, and hepatic decompensation. Fulminant liver disease itself is an established risk factor for lactic acidosis. Prudent and timely adjustments of NA dosage with reference to renal function is essential. This is a study of 16 patients with liver cirrhosis and chronic hepatitis B who were treated with entecavir. 5 of these patients developed lactic acidosis during entecavir treatment. All patients who developed lactic acidosis had highly impaired liver function. MELD score is greater than 20. Lactic acidosis occurred between 4 and 240 days after treatment initiation with entecavir. Lactic acidosis was lethal in one patient but resolved in the other cases after termination or interruption of entecavir treatment. No increased lactate serum concentration were observed during treatment with entecavir in the other 11 patients with chronic hepatitis B and liver cirrhosis who all had MELD scores below 18. Together, this data indicate that entecavir should be applied cautiously in patients with impaired liver function. With the availability of more data from real-life cohorts of sufficiently large sample size and long follow-up durations, the long-term safety profile of NAs is now more clearly defined. Together, TAF, with further improvement in renal bone safety profile, chronic hepatitis B patients receiving NA treatment for years and even decades can be reassured that this treatment would bring them clinically beneficial effects with minimal side effects. This would be one of the key elements to ensure drug adherence in our chronic hepatitis B patients. A total of 998 adverse events have been reported in studies with 25 mg TAF. The most frequent adverse events reported were gastrointestinal disorders, laboratory abnormalities, infections and infestations, renal and urinary disorders, and nervous system disorders. Well, this brings me to the end of my presentation. Thank you all for your patience, and now I kindly ask Professor Sabahattin Kaymakoğlu to highlight the key take-home messages.
Thank you so much, Professor Yusuf Yilmaz, for this excellent speech. In conclusion, COVID-19 adversely affects patients with chronic hepatitis B, resulting in more serious conditions as the fibrosis stage of the liver disease increases. COVID-19 interrupted World Health Organization's goals associated with the elimination of viral hepatitis. Performing screening tests for HPV in all patients that are hospitalized due to COVID-19 would reduce these handicaps. Tenofovir alafenamide is an oral antiviral that is effective as well as safer. During the pandemic, with possible disruptions in the monitoring of patients, a potent and safe oral antiviral drug should be preferred. Thank you for your attention.
Yeah, Yusuf, thank you again. We can ask you a few questions. We stated every COVID-19 patients to be tested for HPV and HCV screening markers. A question from Gupse. When should off-label pharmacologic treatment for COVID-19 be stopped in the case of liver function test derangement? Yusuf.
Yes. When we consider as the benefits of off-label treatments are uncertain, in the case of moderate to severe liver injury, for example, ALT more than 5 times upper limit of normal, yes, or alkaline phosphatase more than twice upper limit of normal, or total bilirubin greater than 2 milligram deciliter, or presence of coagulopathy or decompensation, it will be reasonable to stop the drug in this case.
Yeah, thank you. From Ramazan İdilman, TASL said that almost all patients with chronic liver disease have increases the susceptibility to COVID-19, but Easel don't say. What's your opinion?
Whether patients with chronic liver disease are more susceptible to COVID-19 is uncertain. Chronic liver disease in the absence of immunosuppressive therapy is not known to be associated with an increased risk of acquiring COVID-19. However, the liver may be susceptible to SARS coronavirus because of ACE2 receptors, but also some recent data suggest that pre-existing liver disease was associated with worse outcomes in patients with COVID-19. Patients with chronic liver disease had also high rates of mortality compared with those without liver disease. And I think the conflict is related with the published studies time. For example, as also mentioned that a study, I think it was published in Journal of Hepatology, said that in subgroup analysis, patients with cirrhosis had a high risk of mortality. Yeah. And according to the chart PUC scores, okay, there is an increased stepwise fashion increase appears.
Okay. Yusuf, last question from me. I would like to ask question about the patients where tenofovir alafenamide will be used. Should tenofovir alafenamide be considered when side effects occur with the other oral antivirals, or should it be considered in every patient as the first treatment agent?
It's totally depends the physicians. You can start at the beginning with tough, or you may change when you feel not safe related with the bone safety or kidney safety. Totally depends you. In Turkey, we have the chance to start directly tough.
Okay, thank you. First, thanks to all participants, and then many thanks to Gilead for organizing the meeting. Thank you.
Thank you.